Alrighty, here we go. All right, guys. So the first thing we're going to go over is hematology. It's just a quick little bite, kind of a review. It should just be a review of components, and then I wanted to show you a resource that shows you what lab values you actually need to know for the NCLEX. But there's strategy with lab values. For certain things like ABGs, you do have to know the exacts because you are deciding compensation and whether it's metabolic, respiratory, and so you have to know your numbers really well. But for most things in nursing, if you know the general normal, you can look at a patient presentation and it gives a lab value and you can think, is that way off? Right? You're like, okay, they're bleeding all over. It's probably the platelets. That looks low to me. Looks low by itself. Then you can make a deduction. You know, it says what lab value do you anticipate the patient would have? You could be like, well, it's not going to be the BUN and creatinine, right? I'm not looking at kidneys here. I'm looking at platelets, clotting. So there's a lot of deductions you can make without spending hours studying the exacts. With ABGs, you kind of have to know exacts, but we'll just go over hematology real quick. I also wanted to point to, I did make something called the Unit 2 Reading for Key Concepts. This is a summary of what we test on and the basics of what we learn for this content. It doesn't mean you actually should not create a 20-page study guide based off of this. It's like, do I know the steps to a focused cardiovascular assessment and think through it? I would do this, 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 this. It's like a quizzing of your brain. Do I know that section? If you don't know it very well, don't take a huge thing and copy paste it in there. Watch a video on it or something small to cover that topic, because it's not about the detail. In basic med surg, if you know the topic and can apply it, it's not about the details. And I'll show you a couple places where that matters. But that's why I'm saying don't memorize detailed lab values, because it's a waste of time. And every book is, 0.2 off, and it will frustrate you to keep memorizing things that don't really matter. So we'll go over that. But as you can see, there's a cardiovascular section with some diagnostic studies. I put the prompts next to it, the questions you should be able to answer about it. And most of it is the nursing process. What is the definition of this lab test? What does it measure? What do we tell the patient about it? And how do we prepare the patient for these tests or monitor after? Here's some essential medications, cardiovascular conditions. So if it's written here, we want to know what a patient looks like with it. And then I have specific questions like coronary artery disease. You should know what the risk factors are. Anyway, so this is your study guide for checking yourself if you focused on these things. You should be good as long as you're able to apply it to a patient. There we go. So that's in there under, let's see here. If you go to week 4, it's at the very top. It says Unit 2 Key Concepts, and then it goes into Introduction. Altered oxygenation, which is cardiovascular. We're actually starting with hematology today because we should only spend about 15 to 20 minutes on this topic. Just a little bite, because cardiovascular takes a while. Here's a little, in the introduction section, I put what lab values are must know for NCLEX. And this is a guide for you, so you know that you can type this stuff in too. If you go to nursing.com, they have good resources. And it gives you a synopsis. It's not everything. Must knows are pretty limited. Okay, yeah. Hematology PowerPoint, hematology lecture notes are under the introduction. So we're in the PowerPoint right now. You should see blood, bright red blood. If you're in the military, it's blood, blood, bright red blood, drill sergeant. So we yell all the time as we hold our rifles. It's very exciting. All right, so your one objective for this is review components of whole lab, hematological, and associated lab work. So it's a very, it's a one sentence objective. However, that can be very broad depending on how you interpret it. Let's look at what the blood components are. Your blood is really 8% of your body only. The rest is fluid, tissue, some tissue. You know, fluids, your actually fluid component is about 55% at this age. It's more in the kiddos. It's much less in older adults. So about 40% of your body is lean mass, that's skeletal tissue components. Blood is 8%. If you take a piece of whole blood, you have plasma and a little bit over half, and then you have your elements like your red blood cells, platelets, and your white blood cells. Plasma is protein, water, and anything else dissolved in there. So as we talk about replacing blood components in people, we can go ahead and just replace clotting factors if they're born without certain clotting factors. We can replace plasma. You can give albumin. So you could just be giving components of this. If you give PRBCs, packed red blood cells, that's mostly just the red blood cells, the erythrocytes. So we do have to remember that when we're replacing blood. At my hospital where I was, it was every 5 units of blood we gave somebody, we'd have to give FFP, fresh frozen plasma, because you can see red blood cells is not most of the blood. So we have to keep giving the other factors. If they're low in one, we're reading that one level, don't forget that we should be giving the other component too. So FFP is fresh frozen plasma. Who cares? You don't have to know that. It's just kind of interesting. Leukocytes, of course, can be broken up into their component parts. The white blood cells. There's neutrophils, lymphocytes, monocytes, eosinophils, and basophils. As we go into the immunity chapter, it would be important to note which are your first responders, which ones primarily respond to allergic reaction. That is in Unit 3. So next time you see those white blood cells there, and you'll have to know which ones respond first. The organs involved with hematology would be liver, kidney, spleen, bone marrow, and lymph nodes. So your liver, its primary function in hematology is to form the plasma protein and clotting factors. So if someone has an impaired liver, they are really bad at forming clotting factors. So they often bleed. Their platelets are very low. I did post a video on the hematology content called Coagulation Cascade. It's Ninja Nerd Science. He's really awesome. He explains the coagulation cascade really well. You do not, and you should not study it like you're being tested on the components. But if you want a really thorough explanation and can go away with key concepts like, oh, I see how you need clotting factor here to turn into this. You're not going to be tested on, please diagram the clotting cascade. And but if you're learning things about heparin and coumadin and where it attacks the coagulation cascade, this video is very helpful for that explanation. And it's kind of a, if I ever have to teach myself on it, I go back to that video to relearn, because he has nice description and also pictures. It's a bit drawer. Anyway, so it's posted there for your reference. I find it very helpful when you're learning, especially heparin and coumadin and how they work, because he actually shows that on there. But it's not for, you know, an hour of study. It's just an interesting, wonderful video. The liver also secretes bile salts into the small intestine to help absorb and store vitamin K. It also stores extra iron and ferritin. So liver impaired clients, what I see most on here that's impaired for hematology is clotting. So they're at risk for bleeding. They also have low blood pressures. Part of that's because they help form the plasma protein, and so if they're unable to hold fluid inside their veins and arteries, then they have low blood pressure. That's what happens. So kidneys function is to sense when there's any sort of hypoxic state in the body, and then it stimulates erythropoietin to produce red blood cells. So it stimulates the bone marrow to actually produce red blood cells. The reason that's important, we'll go into, there's a video on polycythemia vera, and most people focused on the genetic component of that, like if you're born with polycythemia vera. But we have an interesting community here because we live so close to the foothills or the mountains, that as people go up in elevation, if their body is sensing a hypoxic state or they live in a less oxygenated state, the kidneys actually keep asking for more red blood cells. It senses hypoxia. And so they get polycythemia vera, poly meaning many, cy is cells, and emia is blood. So many red blood cells are created. And so you will see patients come down to us down in the valley from the foothills or the higher elevations, and they'll have very ruddy cheeks, a ruddy nose, thick blood, and it literally is thick. There's too many red blood cells clotting. So because it's so congested, you'd be at risk for things like clotting, any sort of dehydration state, and that blood won't move well. So they're at risk for strokes, heart attacks, and DVTs, really. They're not at risk for bleeding. There's just congested. Think of too much sediment in a hose or something. It's just not moving well. So those patients, they should move down to a more oxygenated area, but their treatment is to bleed them. You can do plasmapheresis or prescribe blood transfusions to them, like giving blood donations. Isn't that a weird treatment? But you might see it because we are in the valley next to the mountains. So any mountainous area, it is an acquired hypoxia causing erythropoiesis, bone marrow stimulation, extra red blood cells, clogging of your veins, and that risk for developing clots. So that's your kidney function. For spleen, after the platelets leave the bone marrow, they're stored in the spleen and they're slowly released. There is a role in producing antibodies too. The spleen is also important for filtering the blood. It removes old and damaged red blood cells. The spleen is something that is really, during a trauma case, if someone has a motor vehicle accident and the spleen is impacted, there's typically a lot of bleeding and it's often removed. We used to think it had little function in our body, but as we're finding, these organs that we thought were extra are not. They have a purpose. The spleen is very important. And in fact, if the spleen has to be removed, it's usually from trauma. That person is forever immunocompromised because of its function with antibodies. And so if you see in any history anywhere spleen removed, or if you're doing your assessment and you notice a scar, do ask about it. Oh, did you have something taken out? What happened here? clean, they are forever immunocompromised. There's no replacement of that. Bone marrow, of course, is a major organ that we think about for blood. It is considered the major organ of creating red blood cells. It also creates white blood cells and platelets. It's only found in the flat bones at the end of long bones. Flat bones and end of long bones. So your sternum, for example, flat bone, major red blood cell creator. Weird, right? Sternum? Yeah, any flat bone. There's a lot of research around them because of its ability to create new red blood cells. And so people do a lot of studies with, can we get these undifferentiated cells to become what we want? Because it has that creation potential. That's a really exciting part of our research now, is things like cancer. My mom was one of the first recipients. She was an experimental recipient of bone marrow transfusion. She was up at Children's Hospital in Seattle, and she had a specialized unit. It was kind of cool for us because I was 5. So I got to go to a children's hospital to visit my mom, who was 28. And those nurses, of course, they played with us and stuff. It was a kind of a cool place for the children to go. But she ended up getting about another year out of it. And she was the last person on her whole unit to die. Everyone died. That's the nature of research sometimes. But it was long enough, and it gave me, it was really important because it gave us real memories of her. So it's not like bone marrow transplant is necessarily curative of a lot of cancer, but it can give a lot of time to things like leukemia. So we still use it. It's still not, you think, oh, I just need a bone marrow transplant. Doesn't mean it's curative, unfortunately, but it can give time. And time, when you're a little kid with a parent, is like, woo, it's amazing. It's a wonderful gift. So I love research. Okay. So what they're trying to do with bone marrow now is direct its creation to figure out what's the on and off switch for creating the type of cells you need. Because that would really help a lot of things, even creating white blood cells that respond to infection, or red blood cells in the case of leukemia, platelets in the case of clotting factor issues or liver disease. So we continue to search and look for new opportunities in medicine. As far as lymph nodes are really interesting. The lymph, of course, carries lymph fluid, which is drained interstitial fluid. It's very superficial. In fact, if you've ever had lymph massage, it's like a 2 out of 10 on pressure. So it's like, it feels like a nice petting. There's no deep tissue massage to move lymph fluid. It's very superficial. The lymph system returns excess interstitial fluid in the blood, which is important in preventing edema. So if there is a patient with edema, you could elevate the legs to help some of that drainage, and you could do a light lymph massage if you're a family member of someone with edema. As nurses, this is not something we typically have time for. It is often asked for, and it's not meant as a slight to patients, but you literally don't usually have half an hour or an hour to do that part. Like, I will help bathe somebody, but I can't stay on the feet and go like this, sorry. And patients will remind you, they used to do that for me back in the day. But coming from as a nurse from back in the day, patients weren't this sick before. They've gotten much more complicated. They live longer with a lot of chronic diseases. And so we're managing heparin drips and acute MIs and a lot of drips and technical things that before we would keep patients in the hospital for 2 weeks to make sure they were completely better before they went home. And that's not the patient we have now. It's just not their characteristics. All right, so if we're talking about lymph nodes, as the lymph system drains the fluid, there are areas that do tend to collect that fluid, and it can get backed up. If there's an area of infection on the body, the nearest lymph nodes will be trying to drain all that inflammation. So if I have a foot injury, my right groin or the back of my knee would likely have the small nodules inflamed. If I'm a nurse and I'm assessing a leg that has a known wound on it, and I feel a bit of a swelling back here or up here in the groin, it actually doesn't worry me because it's a known pathologic process, and I know the body is draining fluid, putting it there, and we need to optimize that tissue release. So elevate the legs, monitor it. But the nodules should be smaller than the size of a quarter and movable and non-tender. Those characteristics would not worry me, and they should decrease over size as infection gets better. If, I'm doing a well baby visit or well kiddo visit, and there's just, increased lymph nodes that I'm feeling, and they're hard and they're big, and there's no known infection, that's where I would do more concerning workup. You guys don't have to learn about cancer, but that's sort of where my mind goes, is could this be a lymphoma, a tumor in the lymph system? Because if I can't determine a cause for this inflammation, and it's hard, non-movable, so I touch it and it's just a rock there, you can see why that would be more concerning. A symptom without me knowing the cause for it is concerning for a nurse. And the reason I'm talking through those two things is that when you're making a decision on an NCLEX question and it says, which one is most concerning to a nurse? Which is most concerning to you? Most concerning is a symptom by itself that you cannot think through what could possibly cause it, except for maybe something really bad. If it's a known process, even if it's a negative finding, oh, patient has a fever, they have known pneumonia, and they're on antibiotics. That's not worrying to me because I'm like, oh, pneumonia. Okay, does that make sense? So be very, when you see most concerning, that should be a trigger to look for something that you can't explain that's bad all by itself. So lymph nodes should be round, oval, or bean shaped. They do vary in size. I'm sure you've all had the feeling behind and around the jaw and the neck. That's normally, it's very superficial, and that's where the physicians generally for upper respiratory infections will drain there. But we have lymph nodes in our armpits. In fact, if you have a breast cancer, that's the place that they look for extension or spread to the body, is in the lymph nodes in the armpits. So give a patient that has a BRCA2 gene and they had their breast tissue removed, they generally also take out the corresponding lymph nodes to that area. The problem with that is we're not supposed to do blood pressure or blood draws or IVs on a limb that has had removed lymph nodes, because IV infiltrates, that tissue would seep up the fluid, and now it doesn't have a working lymph system to drain that fluid. So I don't know if you've seen lymphedema, but it is huge. Have you seen lymphedema? I'm going to show you a picture. It's pretty crazy. So all you out there, look up, Google lymphedema picture. And it is painful. So this is what happens. You see stage 1 is slightly bigger than. We would probably notice this if they're in the bed. You'd get out your measuring and feel and go around it, feel it. Look at how this leg goes. This becomes extremely painful. A lot of the folds will get like deep cuts in them because it's moist in there. It's an accumulation of fluid. So if fluid is close to the surface, it stays pretty wet in there. Absolutely, yes. Extremely painful. And patients who have had lymph nodes removed, if they are flying anywhere, they're more at risk for having lymph retention of fluid. So there are clinics that just deal with lymph issues. There's ACE bandage techniques you can do. There's certain massage techniques. They're not great, not generally curative. It's more of a management of chronic condition. But this could happen to the arm. So you can see this arm. That's what an arm would look like if it wasn't able to drain the fluid. So of course we wouldn't want to do that because our IV infiltrated, or we used a blood pressure cuff and it kept fluid down here instead of draining. We have to avoid medical procedures. So keep that lymph working. It's amazing how much fluid it takes care of, actually. There are 200 lymph nodes found throughout the body. The most are in the abdomen, actually, but those aren't very superficial. That's why there's nobody digging around trying to find the lymph nodes. The places that we assess it are generally the closest to the surface. All right. The reason that, so they filter pathogens and foreign particles. And so if your body finds any foreign invader, any sort of wound infection, inflammatory response happens, fluid rushes to the areas with all those chemicals that help with the inflammatory process, the chemical mediators. All of that fluid is then filtered and pulled by the lymph system, pulled back eventually to get to your heart and into your blood volume or out. Okay, so let's talk about hematologic system assessment. Our physical assessment would be related to whatever we suspect is going on. It would be focused. It's not normal that someone just comes in for a hematology checkup, but if someone had routine labs of low red blood cells, right? Low hemoglobin hematocrit. So you're supposed to take care of this person. You have to think about what symptom they might have and where it might show up on their physical characteristics. You could do a general lymph node palpation. You could do liver or spleen palpation. If a spleen is inflamed, you would be able to feel it. But it usually breaks in trauma. So motor vehicle accident, it would cause the whole stomach to go very firm and distended. But the skin assessment is where we see a lot of this. If someone's anemic, what characteristics would their skin have? They're low red blood cell, low hemoglobin hematocrit. What would that look like on the skin? Pallor. Yeah. What about darkly melanated people? Where would you look? Mouth and here. This would be very white. When I went to the Dominican Republic after the earthquake, well, I know they had a recent one, unfortunately, but the Haitian earthquake, we went over there as nursing students, and there's quite a few communities that lived on an old landfill area, and there was a lot of just natural parasites in the dirt. And the children played in the dirt, have total fun. It's amazing. It was really great fun. However, if any are ingested for any reason, dirt gets in your mouth and parasites grow in your stomach. The parasites feed on red blood cells. And so we would see extreme cases of anemia, and dark melanated children would go like this, and it's just white. And their tongues would be real white, and the mucous membranes would be white. And so we would give them the anti-parasitic medication. Easy fix, and also think about the symptom of that school-age children not having enough oxygen to support their bodies. get distracted and lethargic in school. And so these parasites were affecting their schoolwork too. And so it was nice to do something. You know, you can't just give it to everyone, but if they came to the clinic, just like, go to school, stay in school. It's amazing how these things affect each other. Another skin thing. So if someone has low platelets, they're at risk for bleeding. Where would that show up on the skin? What kind of activities? You'd see, yes, ecchymosis, a bruising, little, you'd see little pinpoint bleeding even. You could see just tiny little petechiae, we call it. They could have shaved and they just keep bleeding. Their nose often can bleed if they've got any sort of mouth. They have to definitely brush with soft bristled toothbrush. Be very careful. It'll show up in the Foley bag. If they have a Foley, there's just bleeding. But in the skin, look for those petechiae and ecchymosis, or areas that won't stop bleeding after you put some pressure on it. Anything else? That's good. One assessment we also do, we keep in mind their religious preference if any of it relates to receiving blood products. So just make a note for that. Yes, okay. So red blood cells, let's talk about the components right now. Here's the normal ranges, but don't get too hung up on the normal ranges. Red blood cell by itself is pretty much non-diagnostic. I don't know that I've ever needed to know this to pass it on to a nurse. We do focus in nursing on hemoglobin hematocrit. You see the normals for females 12 to 16, males 14 to 18. It will vary slightly at different hospitals because lab equipment is calibrated for their lab equipment. You'll have different lab ranges at every hospital. Their normals are not because they thought, I'm going to go up to 0.1. It's because their lab equipment is calibrated to it. So that's the reason for the differences, and that's why knowing the exacts is not important. But if a patient presents with a hemoglobin of 6, you should probably notice that it's way off, right? Patient comes in with hemoglobin of 6, has had bright red bleeding in their stool for 3 weeks. Blah, blah, blah. Like that's how it's presented. So you still will get lab values in your NCLEX stuff, but generally if they want you to know it's off, it is way off. 6 is lower than female and male. Or it will tell you their normal hemoglobin is 14. Today they're 10 and they're pale. That would give you some idea.
No, yesterday when clinical, we're looking at labs.
Yeah.
The minor also precepting another.
Yeah.
And we looked and she was like, what's that platelet count? It said 38.
Oh.
And it was like no 30,000. It was 38.
It is 1,000. So
They were both like, that has to be wrong.
No, I see it all the time, and because I review oncology patients as well. So if you click on it, it'll give the normal, and its units is thousands. So I would write it 38K, so that everyone knows. That is still very low, because I think, yeah. So in CRMC, you would notice the platelets, the normal is 150,000 to 400,000. It would be written 150 as, okay, because if you go to units, it's thousands of. The unit is thousands of, so it doesn't put the whole number in there. But anything lower than 40 is considered admittable. Like it's very concerning. We could give platelets. That would be probably one of the first things we do. We monitor bleeding. We make sure that we protect them from head injury. There's super high fall risk at that point because any fall could cause an issue. Yeah, that is that's bad. So as far as anemias, because hemoglobin hematocrit, we think about anemias like is the body impaired in producing red blood cells? Like, what is causing it? If someone comes with a chronic anemia, we try to determine cause. So we look at other associated lab values, like their dietary iron intake. If they do not take in enough iron, dietary iron, then their the size of the red blood cells is actually smaller. It's just a thing. I think we looked at it in the escape room. It's MCH or MCB. It's the size of the red blood cell. Nobody needs to know that except for hematologists. But we do look at iron level, and if you just take a peek and you notice it's low, then that could be a way that encourages their blood cell count to go up or make it bigger and carry more oxygen. Because really, what is the reason I'm concerned about not having blood is two things: perfusion, making sure we have enough blood to perfuse and oxygenate all of our organs, especially our head if you're standing. That's the hardest to get up to. But also it's the oxygen carrying component. So if the hemoglobin and hematocrit are low, then we're talking about decreased perfusion to your extremities. So anemia can be chronic. It can be what we have anemia of chronic disease, which is basically the kidneys are impaired by chronic disease, or your whole system is, if you're dealing with lupus or something, and there's this chronic stress. What's up?
Just want to see how it works.
Mm-hmm. It works. It's fine. Third semester instructor, Dr. Sandu. You're good. You're good. It's my friend. The other way besides chronic condition like lupus, where your system's just overloaded and you don't take in enough nutrition to create great. Your body doesn't like to create new things if it's not nutritionally whole, or if it's in a stress state, it doesn't do a great job of turning over new, great condition red blood cells. It's working on other things. It's stressed, it's inflamed, it's working on the whole system. So anemia, chronic anemia, we need to focus on iron, having good iron intake. There are so many types of anemia. You'll learn next semester. But generally speaking, associated anemia with lower hemoglobin hematocrit, and there's a chronic component. And then there's, of course, cut, bleed, active blood loss. That would be another way to decrease. Our goal in that way is to, if someone comes in actually a week ago, a hemoglobin of 2. I have never seen that in my life. I've seen 3.5. That's really bad. 6 is a really bad day. 2 is, how are you alive? But they were. They went to ICU and got massive transfusions. And then you try to find the cause. It could be, bleeding, usually a GI bleed where it's coming out the GI system because of an ulcer. It could be from a trauma. It could be because of dysfunctional uterine bleeding, menstrual cycles that are too intense. Things like that can dip the hemoglobin hematocrit. And so we try to treat the cause, stop the bleeding. It's harder if they have a liver impairment because now they're anticoagulated, right? They don't have the platelets there or the coagulation factors to help. Those liver patients also get a backup. They get in bigger congested veins, and the most concerning one are the varices in the back of the throat, because the liver, when you have liver impairment, backs up, it gets congested. You normally have a vein of this size, and now it's getting backed up and stretching, and it has a tendency to pop. It's filled with blood. That's where you have esophageal varices, and you can bleed. They're liver patients, so they aren't coagulated. The doctor would go in with some clamps. So the GI doctor would go in there with some clamps, clamp it off, find it, suture it, cauterize certain lesions. They try to stop that bleeding for the patient. And then you replace a lot of blood. Woohoo! Polycythemia vera is the thing. Poly meaning many, cy, cell, emia, blood. So many red blood cells. That's where we're talking about the kidney is sensing hypoxia. It's creating a lot of extra red blood cells. Those extra red blood cells are inside the vasculature and clogging it up, causing coagulation. Doesn't move well, you need to bleed them for a treatment. And make sure they're hydrated so that the blood that they do have is moving well and not getting stuck somewhere, creating a clot. All right, platelets. Platelets, like we were talking, is in the thousands, but on the lab, it will generally just say 150. Know that it means 150,000. That's the normal. I write 150K just so it's clear, because K means 1,000 and something. Math somewhere, I learned that, I guess. Did you guys learn that?
Yeah.
Am I making that up?
Yeah.
Okay. It's like, maybe that's a weird thing I do. Okay, good. Hallelujah. Thrombocytopenia. Penia means a low blood count. So low thrombocytes, low clotting cells, danger is bleeding. We talked about how that looks like on the skin. White blood cells, normal is 5 to 10,000. White blood cells are indicators of infection, especially if there's a known cause for that infection, but it's also increased in inflammation. So we have to look at that piece critically. If I just see a white blood cell count and I know they have a leg wound, then I'm assuming that's related to the leg wound. The white blood cells, of course, are measured in your blood because the blood draw was up here. It wasn't inside the leg wound. So that means it's a systemic response to that infection. They could still have an infected toe or finger and not have a white blood cell count elevation because locally it's handling it. So sometimes you have small infection that doesn't necessarily show systemic signs or symptoms. So, but if I did, let's say, diabetic wound ulcer, white blood cell count is 17,000. It's usually just written 17, but it's also 1,000. We would get cultures of that wound and probably of the blood, and then give antibiotics. So that order is important. If you suspect infection, they have a systemic response. Maybe they have a fever. Often when someone has a fever, we just go ahead and get blood cultures. You would get the culture and then start the antibiotic. You have to do it in that order. You can't do it the other way. The other interesting thing with white blood cells, of course, the leukocytes is the same thing. We can differentiate. We can look at this CBC and differential. All that means is they've sliced up the different components of the white blood cells, and you can see the percentages of each type. Who cares? You don't have to memorize that now. But we can tell whether it was likely allergic related or infection related. Parasitic related. There's a couple ways we can tell. But also there's something called segments and bands. The reason I mention that is because sometimes when I was in ICU, we would do rounds with physicians and they would say, overnight, he shifted to the left. Like, what is that? I would look on my labs, and it's in your book, so it's important to know, but it's like, I don't see a shift to the left notation on this lab. What are they talking about? It is a nod to the way that old lab techs used to write out how many of what are they seeing in the microscope. So segments are mature red blood cells, or mature white blood cells, excuse me. Bands are immature. They're teenagers or children. They have not grown up yet. So what they do is when the lab tech is looking in the microscope at the white blood cell counts and hand counting them, if they see immature, they'll write it on the left side of their paper. They'll count. Oh, there's 3. And then the more mature are over here on the right. So a shift to the left means we're sending out immature white blood cells. The only reason that happens is because you've run out of the adults. So think of a war. Your body's at war, or we've entered a war. You're gonna send out your 18 to 35 best fighters. If we start going and sending out our 10-year-olds, that indicates we've run out of the healthy ones. Does that make sense? So your body is losing the infection fight if it's shifting to the left. When you see a notation about white blood cell count elevated, bands are elevated, think we have a systemic infection that the body's not able to keep up with. It's not a static state, it's a snapshot in time. So if at that time you brought them in from home, they have a pneumonia, you get this lab value, they've got 12 bands, 12 is bad, 1 is okay. 12 bands, you're like, oh no, we're way behind on the 8 ball here. Give them fluid, give them antibiotics, you know, maybe suction if they need it. And the next time you take the lab, you'll see the bands have decreased. So it's not like you've lost, give up. It's a snapshot at that moment. All of the adults have been used up and your body has called up the 6-year-olds. You're not doing well. So do think infection would shift to the left. And do think we need to support this person with antibiotics and really good focus training so we don't keep getting behind, because they don't have enough to respond themselves. They've gotten behind on their own fighting. That's a pretty common presentation if someone has been sick at home for a while and their wife nags them to come in. So many people are alive because of nagging, I will just say. So what's different about older adults? We always need to point this out. If your NCLEX question mentions an age, it's probably important. So you need to note, is this pediatric? Is it gerontologic, meaning older than 65? Or are we mid-range? With older adults, there is a decrease in bone marrow mass, an increase in bone marrow fat. So it's just worse at responding to and creating new red blood cells. So the hemoglobin levels do decrease, but they are low normal. I wouldn't expect to go in and see 6 as normal. Their normal would probably be 10 to 12, like soft low. But you'll notice a trend. If they're not actively bleeding and they're not symptomatic, we're okay. A symptomatic anemia would be patient is having, is unable, they're like short of breath because they can't, or very, very tired. It's like, you can tell it's a problem for them. It's not a long condition. They're having chest pain because they're not perfused. That would be more of an acute thing. And so we need to look at the older adult and whether this lab value has been downtrending for a couple of years and there's no active bleeding. We're not as worried about a low. They do have decreased iron binding capabilities. Dietary is so important for them. And actually a lot of the taste buds die. So food is less interesting. And so you have to prompt or find a food that they love. I had a great aunt who would just eat Campbell's soup. That's it. Didn't like anything else because of the texture. Nothing else tasted. So you have to work with what people will eat. The interesting thing about older adults, I think this is one of the most relevant things about them, is that their total WBC looks normal on a scan. So if you take their blood, it looks normal. However, in an infection, they don't respond. Their white blood cell count will not increase in response. So if I have a patient who's older adult, they have signs of a UTI, but their white count isn't elevated, don't stop looking for infection there. And in fact, their fever is generally not elevated too. Sometimes it decreases, and sometimes their white blood cell count decreases as well. They don't have that rebounding response. That mechanism is underwhelming, shall we say. And that's why a lot of older adults need boosters for vaccines. Their immune system is not quick to respond or robust in its response. It'll be like, oh, COVID vaccine, cool, I'll send out a couple fighters. But it's not like we get COVID vaccine and sick for 2 days, develop a lot of immunity. That's why boosters are so important in older adults, to re-stimulate, get a little bit more response so you can develop more of those antibodies. So that's kind of interesting. That's all we're going to go over with hematology. It's quick. Any questions on hematology? It should be mostly a review, but just how nursing applies it. Because I'm sure all you had this in pathophys and all of that, but when we're answering nursing questions, it's what does the patient look like? What are they at risk for? How do we treat it? What do we educate them on? All right, so I'm moving over to cardiovascular. And that's about right. So an hour hematology, hour and a half cardiovascular is about correct. Here, from the beginning. I always start with unit objectives just to have them there. The first thing we're going to talk about, though, is cardiac output. And I think, Philip, you had mentioned about the compensatory response of the heart. You asked a question, and I said, it's coming up. This is where it comes up, where we talk about how the body responds, blood pressure and tachycardia and things. Yeah. Let me see if I can find my notes here. Yes, here we go. Okay, so basically cardiac output is the CO. You don't have to memorize this, but this is a good way to think about cardiac output. Cardiac output equals stroke volume times heart rate. The volume of blood the heart pushes out in a minute, and then how many beats per minute. That would make sense. How much the body puts out in a minute is the amount of blood pushed out and how many beats per minute. So logically, that makes sense, but it is so applicable. So the left ventricle contraction, how much blood squirts out. So we have a real problem if we don't have the contractility in the left ventricle to push out blood, or if the ventricle is stenosed, it's unable to, it like holds on to blood because it doesn't have a good effective elastic pump. If you have a heart attack with ischemia in the area, and some of that tissue isn't well perfused and one area isn't squeezing well, that affects how much blood it pushes out into your body. So that would affect stroke volume. Heart rate tries to compensate so that you get what your body needs as a cardiac output. So your body tries to keep the same number as a cardiac output, and it does that by manipulating the heart rate depending on your stroke volume. So we'll go through this a little bit. Cardiac output can be decreased due to dehydration, because that would be less blood in the left ventricle. Heart failure, because an area is not efficient or like coordinated in its contraction, and so it doesn't get a great pump out. That would affect stroke volume. Hypovolemia, same as dehydration, or any shock state, including sepsis. The first and earliest compensatory mechanism is it's going to say, oh, we didn't get much blood on that pump. I'm going to increase the heart rate so that we get more pumps, hoping for more blood. That doesn't always work because your body actually ideally needs some fill time, a relaxed period where blood can fill before you squish it out. If you start to go like this, there's not enough blood getting in there to squish out. So many of our heart medications slow the heart to decrease the workload also, but because you can't just keep pumping iron, right? Get fatigued. But also to let it relax a minute, get some blood, so you can have fewer heartbeats, but a more efficient So it's manipulation of those things. That's what we do with heart meds. So an elevated heart rate without an obvious reason, like severe pain. Sometimes when patients are super anxious or in pain, their heart rate will, but it's a red flag that you have to recognize because it could be a sign of dehydration. It could be a sign of heart failure. It could be sepsis or shock. The heart rate will be elevated and the blood pressure will be normal or slightly decreased at first, just slightly, because it's trying to keep its baseline. If it increases the heart rate and the stroke volume is the same for a while, cardiac output is the same, blood pressure will maintain. So you won't see too much of a difference there. But if you don't recognize it, the blood pressure starts to drop. Because of that high heart rate, less blood's getting out, blood pressure's dropping. If you have heart failure and it's just a problem of the heart pump, it's not efficient, effective, there's an area of old injury from some old heart attack, the blood will back up. But you'll still measure a low blood pressure. So it'll back up into the lungs, you'll hear crackles, or it'll back up into the venous system, which is less likely. Most people back up into their pulmonary system because of the chambers of the heart and how it backs up. If your left ventricle is not keeping up, it'll back up first into the lungs. It's less likely to have a right-sided problem, but we do have some in this valley. The blood pressure will drop so significantly that it's unable to perfuse organs. The first area that you would see less perfusion would be the skin. It's your biggest organ. That's where you might see initial, maybe sweating, but then you get decreased blood flow and it cools and it becomes clammy. So clammy would be a good sign that you've not kept up with your perfusion. And then another organ it likes to shut off pretty early is your kidneys. That's why you see kidney decline. It's like, we're not getting oxygen here. My brain and heart are more important. And then it would go probably to head. So that's where you'll start to see confusion. Once you hit confusion, you've gone through quite a few organs. That's a multi-organ failure at that point. We're behind the 8 ball. And it's not like we did it necessarily. Some people stay at home until they're supremely confused and family brings them in. So when CO equals stroke volume times heart rate is deeply understood, or if you look at a condition and can put that formula next to it and think, why is that happening? Then you will start to see the clues of heart rate, blood pressure, what's going on here, and anticipate the next step. So if you start to see the decline, you can either stop the med that's been started or recommend other meds, recommend fluids if necessary, things like that. So let's talk about number 1. June, 52-year-old woman. She is 6 hours post-op with a posterior spinal fusion. She's afebrile, but her heart rate and pre-op blood pressure were blah, blah, blah. Since her return to surgical floor, her heart rate has been consistently in the 100s. If her baseline is 78 and now it's elevated. And her blood pressure is 100/60. What do we think happened there? What are we suspecting? And how is the body compensating? Is it blood loss? And it's not necessarily only blood loss. In surgery, a lot of fluid shifts happen. So if we're messing with, oh gosh, she's spinal, neuro, there's a lot of innervation. Every single, every nerve pathway in your body is innervated, and stimulation of that, including your vessels. So your peripheral system, your veins, your arteries, it's either stimulated in shock to open and be flaccid or close and tight. In spinal conditions, often it de-enervates. It could just be a shock from just having surgery. But if all of your veins relax and open, there's more space for blood to fill. And so your blood pressure is going to drop. And there will be a relative hypovolemia until you're able to get the nerves working again. For spinal fusion, they do less trauma now. There's a robotic surgery. They just go in and pinpoint where they need and cut instead of just open, just all the things. This would be more shocking than a little robotic innervation, but it can still shock your system. But any sort of surgery, abdomen, they go in and squish, they touch, they go like this with the bowel for the yards of it and look for things. That's extremely shocking to the body. And sometimes that shock shows up by loosening your vein innervation, and it feels like big, it has no tone, like a big empty sack you filled with fluid. It'll wake up. But that's why it doesn't necessarily have to be fluid loss, but the fluid shifts in surgery almost always turns into relative hypotension. They need fluid for a short period of time. And then you have to diurese them. When their veins start getting tone again, seeing that muscle tone, it's starting to be like, oh, we shouldn't be floppy. Let's come back in. Then now you have too much blood. Now you have too much fluid and you have to diurese it out. So yes, fluid shifts in surgery is a big one. So the nurse recognizes significance of the clinical data, and really it's the trend. In NCLEX questions, the number has to be bad by itself as a vital sign to be significant, or they have to show the patient's trend. They're normal to be of any use to you. If it erased her pre-op, the post-op isn't that bad. I would say, maybe she woke up in pain and her heart rate's a little elevated. That also makes sense. So we think of all these things. The recommendation for the nurse for this would be an IV bolus to refill a little bit, so to release. By refilling the left ventricle, you'll get a better stroke volume and your heart rate will decrease. The blood pressure will improve because it has more muscle tone, it has tone in the vessels. If the heart rate stays elevated, I would move to my next step, which would be vein control. That would be normal post-op. Okay. Number 2, James is a 45-year-old man presented to the ED intoxicated, large coffee ground emesis. His heart rate was 110, blood pressure is 80/40. What's our preliminary diagnosis? GI bleed. Yes. Okay. So, heart rate tachycardic, blood pressure low, means this is a pretty severe and acute case. We will need to stop the bleeding, see if it's active. Coffee ground to me means it's been digested in some way. Does that make sense? If it's non-digested blood, what color consistency would it be? Bright red. So you can think about that up and down. If they're having bright red bleeding, rectally, if that's the stool sample you send, I would be more thinking a hemorrhoid rather than a stomach ulcer. If I'm getting dark, tarry stool, that GI bleed, terrible smelling stool rectally, I'm thinking digestive blood, which could be from a stomach ulcer. So these emesis, coffee ground, somewhat digested, it's somewhere down here. I'm not thinking it's right here because it's been digested and then moved up and then expelled. Lovely. What would you do for that? If someone's vomiting like that, we would put in a GI consult. We would check what labs. What do you think would would make them more at risk for having clotting or hemoglobin issues. What organ could be affected? Liver. So I would check his liver function. I'd probably check his alcohol level. I look for alcohol detox over the next couple days. So any sort of trembling, sweating, visual disturbances. They're saying, hi, Mom, to the corner as no one's in, or spiders are crawling everywhere. Then we need to get on top of that. And then I'd send him to the GI physician. They would be NPO. This person would be NPO and get a IV fluid. We're watching for active bleeding. Initially, to improve his blood pressure, we would give normal saline. After we check the hemoglobin and hematocrit, we could give blood to this person, depending on how low the level is. Generally, we don't replace blood until it's less than 7. We used to give blood to perk people up. No joke. That was like literally written in some charts. Like they needed a good perk, you know. We need to put color in their cheeks. But giving a transfusion is a low-key organ replacement. You're taking on a lot of factors that we don't think of from another person into someone else, and there's a lot of inflammation that can occur. So they want us to take it more seriously, give it as needed rather than to create the lovely flush in the cheeks. It's not necessary, although they do feel pretty good afterwards generally. Okay, so that's a GI bleed for sure. Give fluids, GI doctor, look at the liver, do a CWA alcohol assessment, and you've got a pretty good 3 days plan there. For Jennifer, she's a 68-year-old lady. Post-op day 2, so that's where we start to get into infection. 6 hours post-op, not infection. But now we've had a couple days to grow something nasty at a surgical site. She has a hemicolectomy. Ooh, that's a dirty area to do surgery. Partial removal of the colon. Due to a bowel obstruction, her heart rate and blood pressure pre-op were, she spiked at 10, ooh, infection. Heart rate is now 105, blood pressure has decreased by 10 points systolic. So I am thinking it's screaming infection to me in a lot of different ways. It's the trend that's important. None of those are terribly bad numbers. I would also be cognizant of anxiety or pain in that patient. But my dangerous thing I'm going to fix first is circulation. They're in need of recognizing this. One thing we're trying to fight as new grads right now is there's kind of a failure to rescue. Once you notice something, make your recommendation about improving this patient. You don't have to wait till they decline completely. So noticing a trend, what if their normal is 150 blood pressure and this morning they're 130? Mention it. Have it on the note for the physician. I'm not going to wake them at home, but I'll say, you know, she's been trending lower in her blood pressures and we're not even giving her her hypertensive medication anymore. So let's look at optimizing her fluid. Those early cues will help support your patients so that they don't tip over and have that emergency you have to respond to. Saves you a lot of time, actually. I actually used to love being a night shift nurse because I had time to sit there with the chart and assess what is our plan of care, what's holding us up, what are my recommendations for the morning, just as a spot check. So if you have the time to do that, night shift gives you that time. The danger for being a new nurse at night is there is less resource. But you get to learn who's in the hospital, who you can call, and you're kind of by yourself a little bit more, but I loved the thinking time. It was really fun. Patients in rapid response. And what is causing this? I would say inflammatory reaction. When your body's responding to an infection, it puts a lot of fluid and resources into the area of infection. And part of that is it loosens and kind of weakens vessel walls so that you can send chemical mediators to the area of infection. Do you remember that part of the inflammatory system? And so part of doing that is that it gives you less muscle tone or vascular tone. So you have less fluid inside the vein, which is why you end up with that. So if you have less blood in your vessel, the heart doesn't have as much blood to pump out, which affects the stroke volume, which is why the heart rate jumped up. The fourth one is a 68-year-old man admitted with heart failure. He has ischemic cardiomyopathy and ejection fraction of 15%. His resting heart rate is consistently 90 to 100. So what's going on with him? Do you know what normal ejection fraction is? Do you know what ejection fraction is? We imagine our heart beating as it's squishing out blood from the left ventricle. There is always some retained blood in that left ventricle. It never fully pumps out all the fluid inside of itself. So normal ejection fraction is that from our left ventricle, 60 to 70% is pumped out. That's normal. If this person has 15% being pumped out with each contraction, that's quite a bit of retained blood sitting in the left ventricle. And that can happen mostly in heart failure. Generally means that they've stressed their heart at some point, perhaps with meth. That's common in this valley. That's a common reason. And you can have some young people, in their 30s who have, when they're doing meth, it's like work. Doesn't work so well anymore. Or maybe they had a heart attack in that area, and so the pump isn't effective. And so there's so much retained blood in there, and it's only able to do an ineffective 15% squirt out. So that's about a quarter. They're working at about a quarter function. It looks like it would be about 10 to 20%, but if normal is 60 to 70, that's really a quarter of a working heart. So since stroke volume is the other component in this equation, the elevated heart rate is just to maintain adequate cardiac output. Your body knows how to adjust its heart rate so that it makes sure its brain is perfused and that the kidneys get the blood it needs. So at a baseline, 90 to 100 is something we would want for that patient. If we lower it artificially by just slowing down the heart rate without addressing any sort of the pump issues, we could give a med that has an inotropic positive effect. If you're learning cardiac meds now and you're learning about inotropes at all, it improves contraction, contractility. If you improve the contraction, we could potentially see a lowering in heart rate. But I don't want to take a med that just lowers heart rate because it has a reason in this case. Until we improve the pump, I don't want to turn off the compensation mechanism because they won't be able to perfuse. Even though we like the number better, it's not helping the patient perfuse. And so do consider that with a chronic condition. If it's their normal, that's why we're more reticent to change it unless we're improving the actual pumping of the patient. So all of that to say, that's probably the busiest, it's like one slide. But if you understand those components, you can apply it to so many aspects of nursing and what you want to do in your goal. Another one I would posit is an athlete. Why is their heart rate allowed to be lower? Why is their body generally, if they're a very strong athlete, why would their heart rate be 40s and be fine? I know, yeah. Is it efficiency because the contraction? It fills and does a wonderful, wonderful pump. So you'll have a strong regular pulse. They're perfused, they're talking to you. So the first time I see them dipping into the 30s at night, I'm scared as a person that normally doesn't see that. And so I'll run in. Are you okay? I'm like, yes, I'm sleeping. What's up? Do you have chest pain? No. Well, they're mentating well. They recognize me. They know where they're at. They're putting out urine. I'm like, oh, are you an athlete? What's your normal heart rate? Oh, I get this all the time. You guys think it's too slow. Just note it in the chart so less people freak out. It could be normal for them if their heart is extremely good at efficiency and strength and pump. So symptomatic is where we could get concerned. Chest pain, sweaty, saying, I feel like I'm gonna die. All right, let's go into some of these conditions that we need to cover. One's coronary artery disease. And you'll notice there are so many abbreviations in this, or alternate words for the same thing, like heart attack. That could be ACS, it could be MI. Isn't that fun? It could be STEMI, it could be non-STEMI. Same things, different nuances. So I will try to keep going back to what we're talking about and other words for it. That part's very confusing. I'm so sorry. We speak in abbreviations in the hospital. All right, so coronary artery disease. One of the biggest things with this condition you should know is that there are risk factors for developing this, and some are modifiable and some are not. You need to recognize which ones you can change and which ones you cannot. If I say gender, can you change? No, you can. And so that's kind of an interesting thing. When they talk about gender in medicine, they are talking about the XY, XX, XXY. They're talking about literally the DNA component rather than identified sex organs. So when we talk about risk in medicine, it is very much related to the XY, XXY, XX components. So CID is, generally speaking, the slow buildup of atherosclerosis. There's an inflammatory response, which causes injury of the endothelial lining of the vessel walls. What does that mean? That means that there's a small skin layer on the inside of all of your vessels, and certain things we do in life or genetic components cause that to be more reactive, inflame, which can cause injury. It is progressive. We can't see it. What you'll see first or notice in the whole creation of CAD is first there's a fatty streak, then it becomes a fibrous plaque, then a complicated lesion. It's slow growing and what we often see people come in for is, I have chest pain occasionally when I work out now. You know, it's that chest pain in response to activity, because when your body is needing to draw more oxygen in, it's just too inflamed. It can't respond well, and you start to see chest pain. If you have chronic CAD, slow growing coronary artery disease, that's actually a wonderful thing because your body is regulating that. It's noticing that it's less able to get oxygenated blood where it needs. And so it starts to develop branches. It grows out on the coronary vessels, the arteries and veins that give blood to its cardiac tissue. It's growing on the outside of the heart. It's like, wow, I'm not able to keep up. I'm fatigued with. I am having chest pain with this. Your body senses that it's not getting as much energy or oxygen in that area, and it'll grow off little branches of its own circulation, which is very cool because that means one blockage will not shut down a whole system. You'll have these little branches. It's like, well, the big one's blocked. We're going to go around this way. So that's why there is a better survival rate when you get older with this stuff. lifetime years, more developed collateral circulation. And that's why it's very sad, but more common to have heart attacks more fatal in younger people, because they don't have that lifetime of creating collateral circulation. So one blockage in an area could be fatal. So that blockage that we're talking about when we're going into actual heart attack, it does come from atherosclerosis, but it's from that plaque becoming disrupted. When that lesion that grows up, and we'll actually see a video on it, but when it builds up and it's sensed, and then a trauma or the plaque disrupts and it rips off the endothelial lining, now your body sends platelets to stick to it, and the platelets is what causes the clot to block off the circulation, which causes a heart attack. So I used to imagine it was the fatty bit slowly growing and finally blocking, but it's truly not that. It's when it disrupts, it's pushed forward. Let's say someone has high blood pressure. It's more, one huge risk is that that pressure can push on these small plaques, move them off the vessel wall, and now you've got an open bleedy area that's going to have a clot form. That's what causes heart attack in 90% of cases. So high blood pressure could cause it. But the plaque itself growing takes years and years and years. Basically caused by anything that can cause an inflammatory response to that skin on the inside of your veins and arteries. Things like smoking. Smoking is very irritating to endothelial cells, and that's why if someone is at risk, we ask them not to smoke. Also, smoking has some effect on clamping down or closing down circulation, which is not great, but it's the irritation of the vessel walls. Hyperlipidemia. So cholesterol is an irritant as it flows by in the blood. It irritates vessel wall. Hypertension, because of the pressure that's pushing things through. That constant pressure causes injury or inflammation to that wall. Toxins, diabetes, or infection can all cause inflammation of that vessel wall. Diabetes, I just imagine grains of sugar constantly scraping. You're going to have constant inflammation on the cells. So that's a very high risk. There is a type of CAD. It's usually genetic. When we're talking about younger adults experiencing heart attack, there can be a spasming that the heart does, that the collateral veins do in the coronary vessels. And the spasming will close off circulation for a minute. And because the young person has not developed collaterals, it's sensed like there's no blood. The heart can't give itself blood, but it is truly a spasm. So with young people, if we know that's a genetic cause, there are some medications we can give to decrease that chance of spasming. So risk factors. The non-modifiable is age, sorry people, gender, ethnicity, family history, genetics. Can't change it. The modifiable did surprise me a little bit. One's hyperlipidemia, because we can give statins, right, or change diet. Hypertension, we need to treat their hypertension with medications if necessary, or diet. Smoking, obesity, diabetes, because if you're within a good range of sugars, you will not cause the inflammation. So controlled diabetes is modifiable. Exercise, of course, no exercise would be the risk factor. Adding exercise is what you can do about it. Metabolic syndrome, we'll talk about what that is later. Stress causes inflammation. And a homocysteine level, which is an inflammatory marker that we can change with some medication. Our treatment for coronary artery disease is generally understanding the process as a slow moving thing. If someone is at risk because family, dad died of this, mom died of this, age, obesity, diabetes, hypertension, we're going to point out the risk and what could happen, and we're going to do health promotion. We identify high-risk people, decrease their risk factors. The diet, we want to limit red meat, egg yolks, whole milk, because it's high saturated fats and cholesterols, which are by themselves inflammatory. We want to encourage omega-3s and alpha-linolenic acid, which is tofu's, walnut oil, canola oil, flaxseed. How I remember that is the ALAs, is that the oils are going to soothe any sort of inflammation. They're going to coat and calm the endothelial lining. Those reduce CAD risk. There are lipid-lowering drugs you should know about. The most common would be statins. What those do is they decrease the creation of cholesterol in the liver. The problem with statins is they have some pretty significant side effects, and you should be aware of these. Statins can cause what's called rhabdomyolysis. So if a patient on a statin comes into the hospital with muscle aches, we actually take that seriously, because what it means is the statin helps break down skeletal muscle tissue, and it's the only way to excrete those huge broken down muscle fibers is through your kidney. And so it can like punch holes through your kidney mesh, like the filter in the kidney. It really, big muscle fibers exit through the kidney, but on the way out, it's hurting the kidney. The hugest risk for rhabdomyolysis is irrevocable kidney damage. We give those people so much fluid. So they might get maybe 3 to 5 liters bolus, and then we'll run normal saline at 500 mLs an hour for a couple hours, and then 250 mLs per hour to flush it. So that poor kidney has a lot of fluid to soothe it as it's getting out a lot of huge muscle fibers. So rhabdomyolysis, look for those muscle aches. That's a side effect of statin. Niacin is another lipid-lowering drug. It lowers the LDL and triglycerides. So if we're talking about cholesterol, I have LDLs, HDLs, and total cholesterol. Of the LDL and HDL, which one should be high and which one should be low? HDL should be high. You increase it with exercise typically, or genetics. LDL should be low. So that's the order it needs to be in. HDLs you want more of because it actually helps transport cholesterol out. It is, if you have more of them, it helps pull cholesterol along and out of your body. Some people have naturally high cholesterol levels, and if it is a family history, usually means their genetics can handle a little bit more, but it doesn't mean without limits. You need to still reduce the egg whites, the other cholesterol adding stuff. Niacin side effects. Have you heard of this one? Flushing, bright red. And it is so common and so interesting. A lot of people take this who are bodybuilders actually, because it helps promote circulation. But yeah, you see it on the face. Rapid flushing and heat. The side effects are very common. If you want to decrease the flushing, you can pre-medicate with aspirin or NSAID to reduce it. But at a certain point, for some people, that's not tolerable. If you're always taking ibuprofen so that you can have your niacin, is it worth it to you? Or are you going to keep up with it? I don't know. There is some GI issues and hypotension associated, because if you're thinking about where niacin is going, it's flushing. That means it's also leaving your vascular system, which means you could have a bit of a dizzy spell. Combo meds can increase compliance with these because the side effects are so bad. Now they combine a lot of cholesterol meds. So instead of having to take something twice a day, they'll give you a combo med that you take once. You're like, please take this. But there are quite a few side effects. And so some people are going without and just doing the diet route, and great for them. There are also meds called bile acid sequestrants. They stop the conversion of cholesterol to bile acids in the liver. And those are all GI symptoms: belching, heartburn, pain. The problem with that one is that you have to separate it by at least an hour with other medications. And so if you have to take it in the morning, you would take that one at 6. You would have your breakfast at 7. You take your other meds at 8 or 9. You have to separate them pretty extremely from other meds because it will push things out of your body instead of allowing it to absorb. So it's like it holds on to the cholesterol and keeps it in your GI system instead of letting your body absorb it. But if you take it with other pills, it's not letting your body absorb those meds. So keep it separate. So if you're working on your patient in the hospital and you're noticing that some meds aren't grouped together, they will be placed on an ideal schedule in hospital. So the pharmacist has a plan for, we give our heparin at 9 and 2 and 9. There's usually a reason for it. We do want to match what the patient does at home, but if they're doing it wrong, we also need to educate. They'll say, I get up at 8. I want all my meds at 8. You need to tell them why this one won't work. It will decrease effectiveness of all your other meds. So either leave that one out and have a different plan, or separate them. A lot of people just don't know. They think all meds can just be, whoop, take it. Aspirin. Aspirin is wonderful for CAD because, heaven forbid, they do have the slow growing process and a plaque disrupts, so it pulls off, and now the endothelial raw skin is pulled off, and now platelets go to stick to it. Aspirin is the medication that will prevent platelets from sticking to each other, which is wonderful. That's what we want. And so that is something that we give immediately when someone is suspected of a heart attack. And some people are on low dose aspirin for their entire life, depending on their risk factors. A lot of people say, I take a baby aspirin, and that's what it's for. To reduce the platelets sticking. It's given to all at risk for CAD. It's considered antiplatelet therapy, although it's not antiplatelet, it's anti-sticking of platelets together. Another word to be familiar with is chronic stable angina or angina. Angina is chest pain. So angina is chest pain that occurs when the myocardial oxygen exceeds the supply. So that means the heart muscle wants oxygen because it's working so hard, and the supply isn't there because there's plaques, disruptions, inflammations. It's not getting the blood it needs. Chest pain occurs intermittently over a long period of time with the same pattern or onset, duration, and intensity. So if you are someone that chest pain occurs every morning on my morning jog on the treadmill at 6 a.m., I sit down and it goes away 20 minutes later, like it is miserable. It always happens the same way. You are able to treat it, so there's no difference at all. That would be called chronic stable angina. Maybe the first time you have it, you would go to the hospital because at that point you don't know. It's your first time. So if you have chest pain, you really should go to the hospital for a workup. They will check your troponin level. They will put you on a monitor. They will make sure that you are receiving cardiac oxygen supply of some point, and they'll probably give you antiplatelets, like aspirin, to tell you you must have aspirin. If this is something that happens every day or routinely, they would probably send the patient home with sublingual nitro, just that small pill that goes in your cheek or under your tongue that dissolves. Usually in 3 minutes, there's relief of 30 to 40 minutes duration. And what it does is for that period of time, it vasodilates, and so it allows more blood flow to the cardiac tissue so that it's like, oh yes, we have blood flow again. I don't need to have chest pain. So that's the goal, is to optimize myocardial perfusion. It dilates peripheral blood vessels, which decreases the workload of the heart, and it allows more to seep in, gets more blood to the heart. Important considerations with nitroglycerin is that you have the teaching, how you give it. You generally have a little bottle that has a dark film on it or a dark pouch, because it is sunlight sensitive. You can't leave it out in the sun. It's also heat sensitive. You should not keep it in a Fresno car in the summer in your glove box. It will not be as effective. Having it in your purse would be great. Or your man bag, whatever you have. It's just a small little container that you have to keep out of the sun and out of the heat or extreme temperatures, I should say. Fresno doesn't get that cold, so I guess I just don't focus on that piece. But any extreme temperature. You do have to replace it about every 6 months if it's been opened. And they should have it at all times. So that does the instant opening. If the patient is outside, they're on their curb in front of their house, and this NCLEX question is asking you, what must they do before they take this pill? Here are the possible answers. Take their blood pressure and heart rate, sit down, call 911, blah, blah, blah. Out of those three, what would you choose would be your action for that patient sitting in front of their curb at home? Yes, it will sit down would be first action for 2 reasons. One is sitting down brings your heart closer to your head and everything, so it decreases the workload. Number 2, nitroglycerin, if you extremely vasodilate, could make you dizzy and pass out. So you're reducing risk, and you're also decreasing the workload of the heart. I wouldn't say EMS for a chronic stable patient. If they have taken it 3 times without relief, then they call EMS. I would probably call after the second one. If something's different about the presentation, that's called unstable angina, and we'll go into that. But do you see how that would be a safety, and you're helping the actual cause? Most people take the heart rate and blood pressure first, but they forget the patient presentation is they're sitting on the curb in front of their house. That's why it doesn't make sense. We would in hospital be like, oh, come here, give me your arm, sit down. But you almost have to picture the setting when you're choosing the right intervention. If you're deciding between 2, you're like, do they have that? Is that necessary, or is that a me issue? I want data. That's a me issue. What is absolutely contraindicated? If the patient takes this med, I cannot give them nitroglycerin within like 6 to 12 hours. What type of meds? What would give me a huge groin erection instead of helping my heart?
Oh, the nitrate, not nitrate, it's like Viagra.
Viagra, yeah. I forget the class name. It has a unique name now, but it's Viagra, any of the pulmonary hypertension meds. So you don't actually only ask males, you ask females, because they could be on it for pulmonary hypertension, which is the first way it was created. And then they noticed the side effect and used it for other things. But that's an absolutely contraindicated, because if you give that med and peripherally vasodilate, all the blood will go to groin instead of heart. That would be a huge problem, because now we've further depleted the vascular system of the needed oxygen.
I'm sorry, what was that drug class?
It's Viagra. I don't know the drug class. It's
the PDE.
that's it. PDE. PDE 5. Yep. PDE. It's one of those I can recognize, but who the heck knows? You can ask the female if they're on Viagra, especially if you notice they have a pulmonary hypertension history, because it treats that. Yeah, it would severely, the risk would be you would drop their blood pressure so low, and their heart would not be getting the blood. So you'd have two issues at that point. So that's why that's one. So before we give nitroglycerin, we would want to get baseline vitals once they're sitting down. A huge common complaint with nitroglycerin is a severe headache, because you also open the vasculature up here in the brain, and it's a severe pounding headache. If we have to give a drip because they're really having a heart attack and we're just dripping in nitroglycerin to keep blood perfusing, one of the major complaints is headache. So I try to turn up the nitroglycerin so they don't have chest pain, and turn it down for too much headache. So there's a happy medium where there's a little chest pain and not too bad of a headache. It is that severe where they will absolutely complain. Let me die. I hate this headache. You know, it's really bad, and it's expected. So I'm not worried about it, but I do need to know what's going to happen and tell them about it too. Nitroglycerin. All right, we do have long-acting nitroglycerin as well. That's Imdur and Isordale. So those have less of a severe opening of the coronary blood vessels, but it does open gently over time. And so it can be a nice thing. If someone's experiencing chest pain every day and it's minor, if they add Isordale, you'll probably be able to stave off the symptoms pretty well. Causes headache, of course, and it's used to reduce the angina. Tolerance can occur, so they might have to increase that dose. Orthostatic blood pressure with this is very common because you're artificially opening vessels, and so your body's less able to compensate. So when you stand up quickly, if your body's already open quite a bit, it has a hard time closing like it needs to, tensing as you make sudden changes. So slow changes is better, especially when they're on a new med. You can also give nitroglycerin as an ointment or transdermally. So you can give a nitroglycerin patch, or you can take they'll say, apply 1 inch of nitroglycerin. Like, what the heck? You get out a little piece of paper and squirt out 1 inch, and then place it on the skin and tape it. And you take it off when it says to. It says usually at night you take it off. We'll do that in hospital. So if you start to have blood pressure issues, don't forget that you have this topical vasodilator on there. Some people are like, oh no, we're losing them. Let's get fluid, you know, bolus. And then I get them in ICU and I'm like, let's take off the patch, wipe off the ointment. And then so sometimes stepping back and looking at everything they've gotten and looking at the body can help you. All right. So diagnostic for coronary artery disease, we could look at things like obesity, we could look at hypertension, we could look at all those risk factors, give them scores, see who's most at risk. We could take the cholesterol level. That's pretty much where you go with that. You could do a chest x-ray or an echocardiogram or EKG to see how the heart is responding to CAD. You could do a stress test to really quantify how bad the CAD is. And the stress test, an exercise stress test, is like you're on the treadmill, you're hooked up to a machine, and a person's watching you, and you run. They have to get your heart rate up to a certain level of measured stress, and they'll see if it changes your EKG. If your heart rhythm changes because you're running, that's considered a positive stress test. That means you're at severe risk for bad heart attack, and they'll probably go in and do a cardiac catheterization next, which we'll look at a video of that. Do any symptoms that appear during an exercise stress test, that person in the room would tell that person to stop. You know, we don't want to create a heart attack on our machine in the hospital. Even though there's a goal heart rate you want to get to make it really measurable, if the patient starts having chest pain, we're not going to say, keep going, let me see your rhythm change. They'll just stop the test and it's considered too high risk and they'll go to a cardiac catheterization. What else? I have a picture of that. Do have it posted here on the cardiac videos. This video, acute coronary syndrome's detailed overview video, is the most beautiful thing in this world. I love that drawing, but it takes you through the decision process and outside and inside. If you can follow that thinking, you'll be able to pick the right things. But you can see how it flows through the hospital. I love it. But this one, have you seen this one, the angioplasty? My favorite thing is the music. Just kidding. Here's the volume. I'm going to move forward to the pertinent parts. Okay. So the whole time we were talking about coronary vessel perfusion, that is those streams. The coronary vessels wrap around and perfuse. Here's the left ventricle, right ventricle. And so when you read a report about blockages in certain areas, like left anterior descending and blah, 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 we can sort of picture in our mind what part of the heart is going to have damage. The widowmakers affect this one because this is the pump of the heart. So that's why they'll mention which ones are affected. So you can tell on the EKG where the damage is, where the future pump problems are going to be. But those fill during diastole. So systolic is when the heart's pumping. Boop. When it rests, those also fill. They fill during a resting phase. Let's see. Isn't that great music? I love this for how it shows atherosclerosis. Yes. Thank you. So this is, I love this video because it does show what the heart attack is. This is atherosclerosis. Things are getting stuck. The lumen's getting narrowed. Yes, we know. Body. So during this angioplasty, holy crap, it's also called cardiac catheterization. This is done in the cath lab, so it could be called a cath procedure. So many words for it, or even a PCI, percutaneous coronary intervention, or stenting. So many things for the same procedure. So if they're going to the cath lab, they're going in through, generally, it's the radial artery. It can be femoral too, depending on what side of the heart you want to look at. And it could be right or left. And this is the video, the little video going into the part that you want to look at, which is pretty cool, all the way from here. There's the camera. Beating. Love this. Okay, so there's the area of blockage that is in danger of disrupting. This is, they do not rip the plaque off the walls because that would cause a heart attack. They squish the plaque to the walls. Balloon angioplasty. Holy crap, another word. There we go, now it flows. So that was a coronary intervention where they saw the problem and they can go in with a tool and work on it. This is the stent. A stent is a wire mesh that's foldable and you can expand it in the area you want. This is a stent company that makes this video, which is why they're super descriptive about what type of stent it is, how big it is. This is a DES, another freaking thing, drug-eluting stent. So it has anticoagulant built into the fibers and coated over it. The reason is your body will recognize this as a foreign object and attack it, which would cause a heart attack, saying it. So what they found is if they coat it with anticoagulant, it gives it about a year to allow the endothelial, the skin to grow over it. When the skin grows over it, then your body recognizes it as part of itself and it won't attack it. So all these things, can cause heart attacks in so many ways. Oh, yeah. Yes. Yeah, the drug-eluting stent. But that is why after heart attack, patients with this procedure have to be on an anticoagulant for a year. Or else it'll attack the stent and clot it, and then you have a heart attack. There it is. Oh, I love it. They're very proud of their stent. They should be. It's a good stent. There we go. So we did the balloon angioplasty, which flattens it. And then they go back to the same site to keep that lumen open. So now blood flow is restored. There is the skin growth over the stent. When the skin grows over it, it's now no longer an irritant. So I like that video for a couple reasons. One is the music, amazing. And the other is it shows what coronary artery disease actually looks like, which is that slow buildup of the plaque. And it shows that we don't remove the plaque, we squish it. If you remove it, you cause a heart attack. And then we deploy the stent. We can do this all in the cardiac cath, which is called a PCI, percutaneous coronary intervention, or angioplasty, or cardiac cath, same dang thing. One big thing with this type of patient, and when you're learning about diagnostic tests in anything really, is what do we tell the patient about this? Well, one thing is we're going to take a look at your heart. We can go in and see if there's anything we can do during that procedure to make it better. If there are way too many areas of disease or obstruction, or if it's not an area that we can get to, or there's too much damage, they'll be scheduled for an open heart surgery. But we do try to avoid that. If we can do this, that would be great. One thing we need to tell the patient is that they're awake for a lot of this procedure, and they will feel the contrast dye being injected into them during this procedure because they're doing imaging at the same time. They're looking at a screen, at imaging, feeding it to the right spot. That contrast dye is very fleshy feeling. It's warm. And so because the patient is nervous about this test, and now all of a sudden they're having a warm sensation, they often feel like they're going to die if you don't warn them. So you're going to feel warm sensation, that's normal. But generally speaking, when we're adding contrast to patients, what are some key concepts with contrast? What are common contraindications for CT contrast solution? Who should not get this, or who is at risk for allergic reactions specifically? Iodine, shellfish allergies. Iodine and shellfish allergies. They're going to be allergic to contrast. And that comes up in so many test questions in so many ways. When you see, and it's not just cardiac CT, any CT with contrast, allergic to iodine or shellfish is the contraindication. Another thing I would mention is contrast is extremely nephrotoxic. It means it can injure your kidneys. On the discussion board, there is a discussion about CT contrast caused kidney damage, and that's why it comes up in everything. So every CT scan with contrast can cause damage to the kidneys. So you want to be very careful if you're giving it to a patient with chronic kidney disease. Nurse, I would be watching kidney function after. I would be giving extra fluids so I can help dilute that toxic solution to the kidney. And I'd be watching that urine output pretty well. Another thing you bring into it, because we just have to, is these all link together. These key concepts. When you think CT contrast, you need to think kidney damage. You need to think if the patient's diabetic and on metformin, you need to hold metformin before contrast and not give it 48 hours after contrast, because it also kills the kidney. Metformin kills the kidney. Nephrotoxic. So if you happen to do both, you give metformin and send them to the CT scan with contrast, say bye-bye to your kidneys. So we don't do both. So I know that was like a little journey and it doesn't necessarily apply, but every time you think of key concepts, CT contrast, think of iodine and shellfish allergies, then think of your kidney concerns, think of how it feels flush and warm in the patient, and then think, please don't give metformin. That's my brain journey of NCLEX key topics. All right. I love that video. It's so fun. It's a good one. All right. So that's one of the diagnostic testings we do for coronary artery disease. Let's move over into ACS, acute coronary syndromes. It actually contains several conditions. It's an umbrella term. When someone comes in for a presumed heart attack, that's all of this. It includes something called unstable angina, non-STEMI, and STEMI, MI. Good Lord, all the things. So unstable angina, non-ST elevated MI, and an ST elevated MI. So heart attack could be when they're chronic angina, their chronic chest pain that they get every morning on their walk. Now all of a sudden they woke up in the middle of the night and it's really bad and it's really long. They took their nitroglycerin and it didn't go away. So several factors changed in that presentation. A changing angina, however you want to say it, means they need to come to the hospital. It's a presumed heart attack in some way. Some further myocardial damage has occurred because it's different. Something has changed about it. So they need to come in. It's considered an acute coronary syndrome.
Is it the same as a variant?
Variant, yeah. Anything, if any of one of those characteristics changes about it, especially if it happens at rest when it used to happen at exercise, they need to come in to see where the damage is and what's going on. It could have been that they developed tolerance to their nitroglycerin dose. So it doesn't have to mean, oh my gosh, heart attack, but it is a must hospital. It's acute coronary syndrome. It's a workup for sure. The other two are myocardial infarction, meaning an area of injury on the heart is presumed. And we're defining it by what the EKG looks like. You are not in the business of looking at an EKG this semester and diagnosing it. Your case study had one on there for kind of practice, But you do not have to memorize the areas of injury on an EKG or what it looks like. Yes. That's next semester where you learn heart rhythms, but you don't even have to learn that one. But ST elevated, MI. It's very visual. Do you see how there's a peak? The different parts of the heart rhythm, this is a good one. The different parts of the actual rhythm of the heart. So if this is normal, here's the S and the T. That segment, ST elevated MI, notice how high it is. So here's the baseline. We expect a little cardiac spike like boop, boop, boop. But if it went boop, boop, looks a bit like a tombstone, is how I remember it. Tombstone's a bad sign. So it helps me associate the severity of not responding. Of course, the higher the damage, the more pronounced. Do that. See this one? Here we are. You'll learn the different segments of the heartbeat next semester. The P wave is just your atrium contracting. Little stimulus. They don't have to do much because they're on top. So a little squish is necessary, hardly anything. Small electrical response, because this is electricity. It's not necessarily means the heart's moving. But the P wave is the atrium. The ventricle depolarization or contracting is the big spike. ST elevation is your heart relaxing and getting ready for the next heartbeat. And that's the period that we elevated off the baseline. So that is an ST elevated MI. If I'm looking at an EKG, which looks like this, like holy crap, why and what? All of these lines are not ST elevated MIs. I'm noticing some in V1, in V2, V3. And as someone who's done training, I can associate that with a part of the heart. Yeah, I'm going to show you an inferior wall. Widowmaker. It's not a very nice name. Do you see how pronounced that is? That is an ominous sign. There's a widowmaker. Huge, huge damage is shown to the electrical heart, the contractility of the heart. This is a damage to the electrical system. So if it is that pronounced, there's a goal. ST elevated MIs have to go from door to the cath lab within 30 minutes. 90 minutes is the absolute must for door to balloon angioplasty, but there's goals for all these things. So we want the EMS to be calling and getting the cath lab ready. I think it's 90 minutes is the absolute must. Door to balloon angioplasty goal. Yeah, it's on here. It's on the spreadsheet, but we have markers with all this. So to get this result, to figure out what it is, one of your key things you do when someone comes in with chest pain is to put them on an EKG. Always. Chest pain, EKG. Even if you're like, are you sure it's not GERD? You're not belching too much. You're pointing here. I don't know. Just get an EKG. If the physician sees cardiac damage, it helps us treat them appropriately. So non-ST elevated MI, also called an NSTEMI. Here's good. Normal. There's that weird ST elevation segment is up higher. Non-STEMI does look different, but it's not the same ST elevation. There's just usually a change, or the T wave is flipped. We usually have that nice little bump. Instead, it's upside down. That tells us something has gone on, but it's not a huge assault to all of the layers of the heart tissue. which is why they can stay overnight for observation and maybe go to the cath lab in the morning. Alrighty. So all that to say, those are all heart attack issues. They have different pathways of treatment. And the location of the damage can be told. You can see on the EKG after training, you'll be able to highlight, oh, V3, V5, V6, that's lateral. You know, you'll know what part of the heart is affected. Diagnostics for acute coronary syndrome would be EKG. You need that to figure out what level of urgency you have. Cardiac markers. What is the best marker, the lab value for cardiac damage? Troponin. There are other things you can measure. You can do myoglobin, you can do CK, MB. There's a whole bunch of markers you can do. But if there's one I would choose, it's troponin. And that's because it is specific to cardiac tissue. If you notice that a troponin level is in the blood, so you drew your lab and there's troponins running around, that troponin came from the heart, meaning there was some sort of stress or injury or damage to the heart. That can happen with a big punch, airbag injury. So, but it's still damage to the heart. We would observe them. It doesn't have to be heart attack. The other markers are not cardiac specific. So if you start to have skeletal muscle breakdown, you have major trauma, if you worked out too amazing in the gym and you have a lot of trauma in recovery, it can look like you're having some elevated other levels. That's why I don't want you to focus too much on them. The best indicator of cardiac tissue damage would be a troponin level, because it should be inside your heart, and instead you took the level out here in your blood. It has gotten out. So that's what I want you to think of. It is measurable, it's timeable. You'll notice a peak and then a trough after cardiac damage. So let's say seatbelt or airbag hits you, damage occurs, troponin will peak, and then I'll see it drop off. Troponin is usually always ordered ×3 initially on a patient. Every 6 hours, they'll take a level. If they notice it's just steady, that means it's long-term chronic damage. Patients with kidney disease often have this kind of stressor on the heart always because of fluid overload, honestly, and there's a slow leak. That's not an acute heart attack. You'll notice that for the last 3 years, it's been 0.30, 0.30, 0.30. It's still positive, but it's not peak. Heart damage occurs. You'll notice that the negative is 0.030. And then maybe the first time you take the lab, it's normal. It peaks in about 6 hours. So they're having chest pain. You take an EKG. The first troponin is negative. That doesn't mean it's not heart attack. You need to take the next in the series because you might see it go up then. Oh my gosh, it's 1.030. Oh my gosh, it's 5. We are way up there. If the series is continuing and you're still going up, you want to take the next. I didn't get that. Sorry, Siri. You'll want to take the next lab. So you continue taking labs until it troughs, until it goes over the hump and down again. Because that's when we can see the end of myocardial injury and the start of repair. Coronary angiogram is actually what we watched. So that's a diagnostic. We could go in with the camera, see blockages that have occurred, and maybe just look at the viability of the vessels around that area. Okay, so this is the algorithm that video follows. There's one piece on here that I'm definitely going to talk about that I've highlighted and changed. So this, if you work in an ER, you're going to get very used to working off algorithms, kind of like a checklist for patients. most patients, when they come in, you're going to draw labs, you're going to put them on a monitor, get vital signs and blah. But with this cardiac patient, we have markers we have to meet. Within 10 minutes, you need to check vital signs, get IV access, and do a physical exam. If there is a STEMI, an ST elevated MI, so you did that EKG, if the EMS did it, they have to call the cardiac cath lab to say, I see this STEMI. They send it over, and I was in the transfer center at CRMC. They would call, send it over, we'd send it to our cath lab, we'd call in our cath lab, and they're waiting there. But if they just show up to the ER, chest pain, we send them in back, we have to activate the cath lab if it's an ST elevated MI. We would take the troponin. We might get a chest x-ray because someone with pneumonia could have chest pain from a respiratory cause. Also, you could see maybe a chronic condition like the cardiomyopathy, which is the overgrowing of the heart, means that it's been a long-term condition where the heart has been overworked. Just like if I'm just working on my biceps all the time, they're going to get bigger. Cardiac too, it's stressed, it's going to get bigger. We can see that size in the chest x-ray and lets us know that this is more of a chronic condition. Our immediate treatment is probably something that you've heard of as MONA, but I want you to question the M in MONA. That is not, I don't run in with morphine to a patient in a heart attack. I can, but it's not the first thing I choose. I want to optimize the tissue perfusion. So we start with nitroglycerin and aspirin and oxygen only if they're desatting. Oxygen is variable. You always consider oxygen, and it's not wrong necessarily to put it on if you're deciding. But the best thing for you to do is get the aspirin so we don't have more clots forming. And then give that nitroglycerin. MONA, so morphine, is for refractory chest pain. If the nitroglycerin doesn't take away the chest pain, we consider adding morphine. But we also can consider that it can, if a heart is struggling and you just gave it something to relax, it might not work again well, contractility for a while. You could put it more into heart failure. So don't run in with the morphine. Obviously, if the physician's like, morphine, oxygen, I mean, do it. It has to do with where the damage is on the heart. And you don't need to know that right now. Just be careful that you're not just following an acronym to treat somebody. Make sure it's actually helping the cause of it. So MONA, be wary of oxygen put on the person if they're desaturating. If it's less than 94%, put it on them. Once the EKG is interpreted, the ST elevated MI, do not delay reperfusion. Time equals tissue is one of the best concepts of ACS. The longer they've had the symptoms, the more tissue is potentially damaged in the heart already. And if you think of a wound, if you just get a wound here, you've got a slice, the tissue looks pretty good. It might be bleedy, but there's good bounce to it. The tone is there. But let that thing, dip that thing in water and sit it there for 12 hours, and it's been damaged, not perfused well. I imagine skin and tissue that's kind of like gray, boggy, leaky, gross, potentially. That happens to your tissue inside as well. The longer it's been damaged, the less viable tissue it has. So reperfusion, if we're considering that this patient had an ST elevated MI, that means they had a severe blockage in one of their vessels at least, and it stopped perfusion to the body. You have a certain amount of time to get that blockage out. Otherwise, it is not worth it. So let's say it's been 2 days, severe heart attack, oh my gosh. You go in and pull out that clot, and behind it is all this diseased, old, sick, leaky, injured muscle. You can't reperfuse it. The blood's just going to leak in there. Oh my gosh, it's not worth it. So you don't go in and remove clots and things that have been leaky and gross for a while. You're going to cause bleeding and more trauma, and it's not going to wake up the tissue because the vessels are leaky and damaged. They haven't been perfused. They've died. And that happens with your brain too. The longer you have the symptoms up here, if it was caused by a clot, if they've been confused for 3 days, last known normal was 4 days ago, we don't rush in, even if we see it, we don't rush in and pull it out. Because if the tissue behind it is boggy, leaky, gross, all the blood is now going to just leak out. And now you have a hemorrhagic stroke. Congratulations. Ischemic into hemorrhagic. Same thing happens. So you send people who have had symptoms less than 12 hours because they have a chance of viable tissue that can be reperfused, meaning blood can go back in it, not leak out, reperfuse, wake up, lessen damage. That is it. So at home, I definitely want you guys to review hypertension. And that is not fussing over the stages necessarily. You should know you're normal. And you should know when you're getting into stage 1. But we're in basic health conditions. And so know what the patient comes into your clinic and has one-time hypertension value. Think about that we don't diagnose hypertension off of one value. Ever. They could be stressed that day. Maybe when the person took the blood pressure, as always happens in the doctor's appointment, I think you know this. You walk in, you sit down, you hold out your hand and they do the blood pressure. You're supposed to have been sitting for 5 minutes. So it could be elevated from that. A lot of people have white coat syndrome, and it increases as you're elderly. And so every time they sit in a doctor's office, it spikes up. How you would diagnose that is have them come in 3 times to see it. 3 times measurement equals hypertension. But for that white coat person, I would actually have them use the blood pressure cuff. Either I send home with them with a home health nurse education, someone calling on the phone and saying, okay, sit down now. I'll call you back in 5 minutes. Walk them through it so they're not in that environment. Or have them use the one at CVS, Walgreens, and tell them sit down for 5 minutes before using it. And they track their own blood pressure. If you suspect it's white coat syndrome, get the blood pressures outside of the environment that they're stressed by. Hypertension is a silent killer. So think of the damage that can be caused to your vessels, especially your very sensitive filters like your kidneys, your brain. You can cause those hemorrhagic stroke if there's an aneurysm in there. If you have some sort of weakened area and you're pushing blood hard through it, it can pop, right? So that would be a hemorrhagic stroke. You can get CHF because it's overworking because there's so much pressure. And your eyes, definitely your eyes can develop symptoms because it's a really sensitive filter. It's very sensitive to hypertension and kidneys. So yeah, the rest of this is how is the cardiac system different in older adults? Vascular disorders, I put pictures of because it is very picture oriented. You should learn DVT. You should learn Berger's and Raynaud's disease. So the top is Berger's. This colorful one to the left is Raynaud's. This would indicate DVT. You notice the swelling and the redness. They'd be able to point to a spot. I wouldn't massage that leg because the worst thing you could do to an embolus or a clot is to get it mobile, so it lodges in your heart and lung. So don't put SCDs on this guy. Put it on this leg only. And measure here and send them to an ultrasound. We would use Heparin and warfarin. Warfarin takes a few days to get to therapeutic level. So in hospital, they have heparin and warfarin. When they get to therapeutic level on warfarin, we stop heparin and they go home. Vitamin K is the antidote to heparin, or Coumadin really. So if they need to have a steady dose of their leafy greens. So we don't tell them not to have leafy greens, but we make sure that they're having their home diet and kind of titrate it well so that we get them the level that allows them to eat their leafy greens. So that's called heparin bridging. You should know that. You should know the therapeutic INR for Coumadin. And it's on your study guide sheet. These two are my favorite. Buerger's and Raynaud's is not something you have to know in depth, but you have to know what types of patients have it and what their treatment is. Raynaud's is beautiful rainbow colors in the peripheries. This is a spasming disorder in your peripheries. So cold and stress can cause it. Hormones can cause it, most common in young women. If you're in cold environments, stressed, AKA when I was in boot camp, there was a girl who had this. Fingers go white because there's no perfusion when spasming, and then it releases, and so it goes purple and blue. That person should not work around heavy vibrating equipment like construction because it'll cause it. And to make it better, you can dip it in warm water, not hot, and avoid precipitating factors. So calm down, get out of the cold, things like that. This one is young men. Buerger's disease on top is a small clotting disorder where little microclots lodge down in the peripheries, and that's from smoking, almost entirely smoking. Treatment is no smoking. So that's as in-depth as you need to get at that. Recognize, I think, young men Buerger's and rainbow Raynaud's is young women. Treatment, warm water and avoid the precipitating factor for young men, stop smoking, the end. So that's why I'm saying don't fill out a 20-page study guide, guys. I could write a page and a half on Buerger's and Raynaud's, but that would be ridiculous. Look at the picture, differentiate the population, know the treatment, the end. That's it, you guys. Thanks for hanging with me in this weird, wonderful world. All right. So any questions on any